Hi everyone, good evening, and thank you for joining us for tonight's update in partnership with St George Hospital. My name is Lauren Thomas and I'm the CPD Program Officer here at Cessburn. I would firstly like to start by acknowledging the traditional custodians and sovereign people of the land across which we work, and I recognise their continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. Please note that this session will be recorded and will be available on the Cessburn YouTube channel within the next couple of days. At the end of the webinar, an evaluation survey will pop up on your screens. Please complete this to allow us to issue your certificates of attendance. To submit a question, please type your question into the Q&A box in the menu bar and we'll endeavour to answer it possibly at the end of the session. Tonight's event will be accredited for 1 hour of educational activity. We will submit your CPD activity with RACGP on your behalf. On the line tonight, we have our GP facilitator, Dr. Martina Gleeson, who is a local GP and clinical lead at Southeastern Sydney Health Pathways. And tonight, our speaker is Dr. Anna Dosen. So she's a senior paediatrician, having worked in the St George area for over 25 years. She holds positions at St George Public Hospital, Sydney Children's Hospital and UNSW. She's also a member of the ASCIA and the National Allergy Council. Her special interests are food allergy, anaphylaxis and current approaches to allergy prevention. Thank you for presenting tonight, Dr. Dosen.
Thanks very much, and I'll put my screen to share. And okay, so please put your questions in the box. I'm going to be talking about allergy in children, and hopefully at the end of this session you'll be able to have some better knowledge. The areas I'm going to try and cover tonight are food allergy, anaphylaxis, allergic rhinitis, eczema, and current preventive strategies for allergies. So I gave a talk to paediatricians 2 years ago, and I reviewed my own practice. And this is a review of my own practice, where I basically was seeing half and half males and females. I was seeing about 26% were new patients, and the age distribution was primarily a lot were in the infancy period, and very similar to other studies. Most of my early childhood were eczema, food allergy, and my older children were mainly looking at asthma and rhinitis. And again, when I looked at my core diagnoses, they were food allergies, anaphylaxis, rhinitis, asthma, and eczema. So this might be a little boy that might pop into your practice who has been fed a potentially allergic food. He looks very miserable. He's dribbling, he's vomited, a little bit red in the face. This is sort of a classical presentation of an acute allergic reaction. When we're looking at food reactions, this old slide tries to divvy up the reactions amongst what could be related to the immune system, such as your IgE. Then there's also non-IgE, but still part of your immune system that's working through other factors such as IgG or eosinophils, and also cell-mediated like T cells. And then your non-immune is where you might get mixed up, where parents come and say, my child's had a milk reaction, and they say it's lactose intolerance, but really it's probably an IgE-mediated reaction once you hoe down onto the actual presentation. You can also react to toxins in fish, or you could react to chemicals, or you could react to caffeine might give you not an allergic reaction, but might make you vomit or make you feel sick in the tummy. So when we're looking at food allergies, I'm looking at the immune system that's going to be reacting, and primarily we're looking at IgE. The symptoms usually come on very quickly, symptoms like rashes, hives, swelling, and vomiting. And normally these reactions are triggered by food proteins. And that's important to understand when you need to explain that to families. So the non-IgE reactions I've mentioned briefly may look exactly the same if they're vomiting. They're usually more delayed, and they can be from proteins, but they can also be from sugars like lactose or toxins, and they can give you diarrhea. And you have to sort of get a good history as to when the reaction occurred to understand if this is an allergy or perhaps an intolerance or non-IgE reaction. So with some gut reactions, they can still be mediated by immune cells like IgG or T cells. And there's a whole lot of them that are still considered allergies rather than intolerances. So the baby who presents with bloody mucousy poos, the enterocolitis, the kids who have problems that present like reflux, but actually get food impaction, and that's eosinophilic esophagitis. The enteropathies could be the babies whose gut is not absorbing proteins, and then they'll fail to thrive or have abdominal distension. I do put atopic dermatitis down here, and I'll talk about that a little bit further. Particularly, you see a lot of eczema and families calling for allergy tests, but we'll talk about that towards the end. And then I love this chart, and I'm not sure how many GPs have access to UpToDate because you usually have to pay for it. But being part of the public health system, I have the luxury of being able to look things up easily. And this has the IgE-mediated reactions, which are the quick ones, the anaphylaxis, immediate reactions in the mouth, and exercise-induced anaphylaxis. Now, eosinophilic GIT issues and eczema can have IgG rather than IgE. And then you've got the non-IgE, which tends to be T cells that are leading to often the colon being irritated. So I beg your pardon about that. Constipation is an interesting one. Some gastroenterologists really believe that constipation can be mediated by certain excessive foods, particularly dairy, but that's also hard to prove. So when we're looking at the non-IgE and the intolerances, there isn't any really good evidence-based investigations for these type of food allergies or intolerances, I should say. And then there are families that might go and see alternative practitioners who might have hair analysis or kinesiology, and none of these have consistent results. And so it's really a detailed history, excluding what you think is the problem, and then reintroducing it to see if the reactions occur again. So in Australia, up to 10% of 1-year-olds may have a food sensitivity when we take a detailed history and then may go ahead and either have a serum IgE or a skin prick test. And then of those, about half of those were found to react if they went on and had an actual food allergy by testing through a food challenge. So I think it's really important to understand that a positive test, and I'll talk about that also as we go along, is not always correlated with a reaction. So you really need that history. Overall, if we look at worldwide, if we look at 12 months olds, 6 to 8% would have a definitive allergy by testing and history. And as children age, about half of those will have ongoing allergies. So if you just have in your head about 8% of the infants at CU probably do have a bona fide allergy, and about 3 to 4% of children when they're starting school would probably still have that allergy. Interestingly, in Melbourne, they found that first generation Asian Australian children had 3 times the rate of peanut and food allergy compared to their Caucasian peers. And the reason for this is still not quite understood. These are our most common food groups. I call them the top 9. Cow's milk, egg, peanut, tree nuts, wheat, sesame, soya, and shellfish and fish. And if we look at the distribution, most of the egg and milk will be in the first year. The nuts and wheat tend to be a little bit later, and the shellfish and fish tend to be even later when they present. But the take-home message here is that any food can give you an allergy. The most common ones in infants are the egg, peanut, and cow's milk, but most common ones in adults, because food allergies can persist in adults and also seems to be increasing in some of our geriatric population, tree nuts, sesame, and seafood. So if you've got a good history that they've ingested the food and they've developed immediate hives and facial swelling, then that should be suspect. Recent studies have suggested that unusual foods are becoming more prevalent, such as buckwheat and lentils and peas in different populations. And I think that's got to do with what food is introduced at what time in your time of life. And what about, when do these foods go away? So most children with cow's milk and egg allergy will improve by 5 years of age. So generally, if you can remember that 50% of those with cow's milk by the time they start school will have resolved, and then even more by the time they're 10. And egg, again, usually 50% by the time they're finished preschool, and a bit more by the time they're finished 9 years of age. But the sad news is that peanut and tree nut don't appear to have the same resolution as cow's milk and egg. Some studies do suggest that maybe up to 25% of peanut allergy may improve by 4 years, and tree nut is less likely to outgrow, which is sad. This is a lovely chart. This was done by my colleague Eric Lee, who was the immunology fellow at Randwick, and this is a paper from Current Allergy from last year. And it's a really nice understanding that milk's the first year, egg towards the end of the first year. This is wheat that raises its heads here, and then we've got peanuts, tree nuts around here, and then fish. So if you follow the line, you can see that a lot of the foods, by the time the child is 2, has peaked, and then wonderful resolution for egg and milk, but not so good for peanuts and tree nuts. So moving on to anaphylaxis, which is the most severe form of food allergy that may be presenting to you, hopefully after they've been to the emergency department, but sometimes they may be presenting to you because they're near your surgery. And it's difficult because the definitive diagnosis has been not well agreed on. The reason I put this up is there's a lovely video of a child having anaphylaxis. Now, I don't know if I'll be able to show it to you. I might have to put a different screen up. If I stop sharing for a moment and see if I can go to a different screen. So just bear with me. Are there any questions so far while I'm trying to work on this? Let's go to share screen.
Yes, there is a new question. I had a patient who developed severe abdominal pain and diarrhea following peas, but no other food allergies. Is this allergic?
Soon after, it may be, like if it's within an hour of consumption. If it was in a delayed fashion, you might think about it as being an intolerance rather than an IgE mechanism. You could think about doing serum IgE, or you could think about a re-challenge to confirm it if there was no other symptoms. Okay. All right, let's see if this will work.
8:40 a.m. and you've just had 5 spoons of yogurt. Okay, I'm going to turn it off now.
So now you're going to see the child having symptoms. The redness around the eyes, drooling. He's making a stridor. He's still quite alert, but that's a child that's quite quickly progressed to what I'd call anaphylaxis, and I'm hopeful that they went and sought medical attention. Okay. Here's another picture of a child with quite severe swelling of the lips, quite lethargic. Here's a picture of significant urticaria. So I'm hoping that those signs of someone that acutely presents with respiratory upper airway noises, lethargy in the younger child, you should really be thinking about anaphylaxis. So currently, the definition is an acute life-threatening systemic allergic reaction indicated by any one of the following, such as difficulty breathing, swelling of the tongue, difficulty talking, hoarse voice, wheeze, or persistent cough. This one's a tricky one. Persistent cough, some people think of as asthma, but in the context of a child who has had exposure to a suspect allergic food, you'd have to think about anaphylaxis. Dizziness or collapse in the older child, or being pale and floppy in the young child. So previously you need to have 2 systems, but now ASCIA and the World Allergy Organization and also the National Allergy Institute in America would consider any one of those. There are more complex definitions. Oh, and don't forget, with insect stings like bee venom, you might just get vomiting and abdominal pain and redness. You would consider that a significant reaction because it's away from the point of the sting. So don't forget that for a bee sting, and that's also anaphylaxis. This is a much more complicated diagnostic criteria where you have to have at least one of the following: respiratory or decreased blood pressure, 2 or more of the following occurring rapidly after a likely allergen. So here you've got skin, respiratory, decreased blood pressure, and then reduced blood pressure after exposure to a known allergen. I think this is really complex, and for the purpose of someone that might be coming into your clinic, I would just be going with the previous criteria, because you want to treat this child or older child quickly, because they could go on to have a much more severe life-compromising event where the lack of adrenaline given early has been shown in studies to have a poorer outcome. So here's a lovely little just thing that summarizes what that person might look like coming into your practice. What are the predictors for someone who is most likely to develop anaphylaxis? Well, they're all really poor, really, really poor. There's some evidence that if you've got previous asthma and you have previously reacted to very small doses, that you at higher risk. If you've had contact with that food or allergen on your skin and you react, that is not a good predictor. The type of allergen, again, not always a good predictor, but tends to be a worse reaction for tree nuts, although recently milk has been a problem in some children with deaths reported overseas. I'm not going to talk about the basophil activation test, but the thing to remember is there's not really very good predictors, and there's not a good blood test that's a good predictor either. You also should remember that infants may not have a lot of respiratory symptoms. They may just get really floppy and get sort of hives. And that should alert you to a potential anaphylaxis. In big studies recently published, most severe allergic reactions for children occur at home, and for adults and adolescents, it tends to be in restaurants. And those people with the highest mortality were actually the young adults. So for the general practice, I think it's really important to understand that when a child or a teenager leaves my care and they're waiting to see an adult allergist, it's important to reiterate the importance of carrying their EpiPen when they're eating out, because they're the high-risk groups really who've had poor outcomes. So how do we diagnose food allergy, whether it's anaphylaxis or just the skin reactions? The core aspect of it is really the detailed history and recognizing the clinical features that are consistent. And the skin prick test or the serum IgE, that's really the correlation that confirms your history. So when families come to me and say, I just want an allergy test, that's not really doing them any favor. You do have to spend some time sitting and talking. What was the reaction? How soon after the exposure to the food did it occur? What type of symptoms? Was it self-resolving? Did they need to have treatment? Did they need to have any other intervention? And remembering that having a positive skin prick test or a serum IgE is called a sensitivity, but that it does not correlate with having an allergy. An allergy is when you actually have that reaction, whether it be the rash, the vomiting, the anaphylaxis. And doing the skin prick test helps us confirm the story that we've taken, the diagnostic element, that this is likely to have been that food that caused it. So if we look at what a skin prick test looks like, I don't know if any of you've seen what a skin prick test looks like. So this is a hive and then the surrounding of erythema. And we tend to measure the X and Y axis. So reports that you might get back from other immunologists might give you a mean. So they might measure the size and say it's 4 by 4. So then they would report that as 4 millimeters. Or in this case, this might be like 10 by 6. So they might report that as an 8 millimeter. Or you might get a report of just the X and the Y. So that's what a skin prick test looks like. Askia has a wealth of information that is free for you to use. It helps explain a lot of things, including what is a food allergy test. They have also information about different foods and what to avoid. They've got information about anaphylaxis, and of course, they've got the action plans. So I would encourage you to use that for lots of information and day-to-day use. So in the GP setting, where you may not be able to do skin prick testing, you could think about doing serum-specific IgE testing. And I guess this is where it's important to understand, what does it mean? And is it just a sensitivity, or is it truly an allergy? This slide comes from another talk that I gave also to pediatricians, because you may be aware that apart from the specific IgE, these days we can actually do component testing, which may help define which part of the protein the person is allergic to and help us understand if they have a higher risk for having a significant reaction. So if we look at peanut, you can do the whole peanut, which would be on the, if you ask for a serum IgE, or you could do component testing where the number 2 protein here is the one that's most associated or predictive of a significant allergic reaction. Now, in Australia, you can have 5 specific Ig tests that are covered by Medicare, and after that, you have to pay for each individual one. So that's the same for Labadie and Douglas Hanley and clinical labs. So you can order that if you have a detailed history and you want to confirm that it was cow's milk or peanut that the child reacted to. And then usually I say to people, if you're getting to a level above 0.3, that would be considered a significant reaction for most food proteins. So it's kind of a good screening tool, and I would never ever do any more the old RAST, and where you would clump together a whole lot of things like aeroallergens or foods, because then if that comes back positive, you don't know which element that person is truly allergic to or sensitive to. And then if someone in your clinic can do skin prick tests, there are different ranges for different foods for which I, if I was doing it, would consider when I could try to challenge that child. And it's different for different ages. So interestingly, for a younger child, they can demonstrate a more likely reaction at a lower level than an older child, where you would often find that if we challenge them, they may not react if the skin prick test was actually sitting at a higher level. And that's sort of counterintuitive, but it's actually what we've found when we do testing it. And some of the reasons for that is that often the skin prick test might be smaller in younger children and higher in older children because of the type of mast cells that are in the skin, and we tend to have less when we're younger than when we're older. But for people who are doing serum IgE, I think there are tables, and as you can see, there are different levels here for which you may be able to introduce that food. So it's a little bit more complex. I think when you get those report backs and they say high, low, or moderate, I think you have to take into account the age and also what that particular food is, because usually you've got more leeway with something like milk, for instance, where you might challenge at a much higher level than, say, you might for peanut. So generally, I think if you're going to get a total serum IgE of 3 kilunits per liter, that would be a child that I would avoid that food. But if you get a test result that's only 1, that would be reported as positive, but it might just be a sensitivity rather than a true allergy. And that's where you might think about reintroducing some form of dairy that's modified, like in a cooked form, rather than in the fresh milk form or formula. And that can be difficult if you're not used to seeing a lot of the results and the result comes back as saying, oh, it's positive. But generally for all foods, if the level gets to 3 kilunits per liter, I would avoid that food and then ask for help from someone like me. I think I've shown that before, and I've shown that before. But I did want to show you this. So these are milk and egg ladders for how we may reintroduce a food for a child who is shown sensitivity or a definitive reaction. And the reason we start with baked goods for milk and egg is that it denatures that protein, so it's not seen by the immune system, the circulating IgE, as being allergic. And it's the safest way of reintroducing both milk and egg. This is not the case for tree nuts. When we cook tree nuts, it makes no difference to that molecular structure. Here, when we cook it, it's integrated into a matrix and it's tolerated much better. So when I'm reintroducing egg and milk, I would always do it in a baked form first. Here, I love milk arrowroot biscuits because there's no egg in that. And then a muffin, and our muffin mixture that Askew uses usually has about 120 mils of milk per 12 large muffins or 24 cupcakes, and also about 50 grams of butter. And here with egg, we're introducing it in a form that's also heated and mixed then in with a fat like oil or wheat. And they're also freely available for people to look up online as well. So if you've got a child who has had a mild reaction, like just a facial rash, and you haven't done an allergy test, and they haven't reacted to anything else, and they don't have eczema, then you might think about trialing it in this cooked form rather than maybe the scrambled or boiled egg, which is often what a lot of babies are being given at 6 months, or cheese or yogurt. And you usually will be fine with all of the baked forms. And then you can defer trying these steps of the ladder till they're maybe closer to 12 to 18 months. So when would you refer someone with a food allergy? Well, definitely after anaphylaxis, because they need to have an EpiPen and they need to be treated with adrenaline because that's the drug of choice, and they need education. If the child has multiple food reactions and you're not confident for reintroducing it at home, if you think that the child, sorry, has a very unclear history and you've done a serum IgE and you can't make head or tail of it, it could be just a sensitivity rather than a true allergy. And if they've just had a self-resolving rash around the face, I'd give you the courage to try that food again. And what I normally say for these younger children, try to put some zinc or some barrier cream, and then try to get the food into the mouth and not all over the face, because it might be just a contact irritation. And remembering back to the anaphylaxis, that contact irritation is not correlated with anaphylaxis, which a lot of families do think is. This next bit is all about what leads you to have allergy, and it's very complex. So you're born with a genetic background. You may have an exposure through the skin rather than through the mouth, and you might have the wrong type of microbiome. So this interface of born with a genetic predisposition, you're exposed to it in a way that probably you shouldn't have, and you don't have enough of the good microbiome, may lead you to have allergies. And then when we're born, we have a naive immune system that doesn't know which way it's going to go and tries to make too much of a response. And then it's when the antigen cells present the protein to the lymphatic areas that have got the T cells that you're going to move towards a T2 response, which then turns on your B cells to make the IgE, and then you end up having allergic reactions. So there's been a lot of work on prevention, and many big studies have found that we shouldn't be avoiding foods during pregnancy and during lactation. That's the bottom line. So when mothers come to you and say, I should be avoiding this, the answer is no. The family should be eating a variety of foods, not necessarily one particular food. If the mothers actually restrict the food, in this study of 8,000 children, these children had more peanut allergy in the restricted group than if the mothers had it. There's going to be a study coming out from WA called the Pregnut study, where they were given, one lot were given the nuts and others were not given as much. And that should be published next year about, again, what should the mothers be doing. During pregnancy, again, lactation, unless you've really got that enterocolitis that develops around that 5 to 6 week mark, the mother should continue having dairy and most foods in their diet without exclusion. So it's quite complex. It's not just one thing that leads you to it, but there's a lot more things that are happening in the field of pro and prebiotics. There'll be in a lot of formulas that have been added, and recently human milk oligosaccharides have also been added to formulas in a way to help prevent development of allergy, as well as some evidence that if you own a pet early on in life, you might have less allergies than if you had no animal exposure. And then also how the gut sees things is really important in terms of allergy prevention. So earlier presentation and not avoiding solids is what the current recommendations are. So I think that has been taken up pretty much by early childhood clinics, and now telling us to do this. And recent studies have also shown that there's benefit by introducing peanut by 6 months rather than waiting till 12 months even. And even this study, they were introducing solids at 3 months, peanut, eggs, and cow's milk. So I tend to adopt a moderate exposure. If the babies look interested in solids, then probably starting a variety of solids from about 4 to 6 months onwards. I do think that with egg allergy, they are prone to quite a bit of skin rashes from contact irritation if the egg is not well cooked. So I still like them to have very well cooked egg if they're going to do eggs at this early age. And again, it's all got to do with having the antigen and getting this Treg response to turn on, and so that your exposure through the gut is where you're going to develop your tolerance. And as you may know, the Nobel Prize for Medicine was given recently for research into T regulator cells, which hopefully will also help us with autoimmune disorders. So exposure early is what's recommended. Maternal exclusion diets are out. There's some evidence that pre and probiotics may be helpful. Studies about vitamin D have been quite disappointing. And human milk oligosaccharides have demonstrated decreased upper respiratory tract infections, but not necessarily preventing you from having food allergies. So there's still a lot of work to be done in the prevention field. And again, there's this lovely document that you can get from ASCIA about what recommendations for foods and introduction for foods. There's one caveat to this, that's a child with severe eczema. So that child needs to have their eczema managed because if they're exposed a lot through inflamed skin, you may develop food allergies, and I'll talk about that shortly. So I just wanted to touch on, well, before we go there, any questions about this before we go on to allergic rhinitis?
There are a few questions, Anna. Just going back to that peas question, the poster said that it happens every time. It was vomiting and diarrhea, and it triggered me to think, how do we tell the difference between FPIES and urticaria?
So FPIES, the food protein induced enterocolitis, classically occurs 2 to 4 hours after ingestion, and you get this profuse vomiting without rash because it's mediated through neutrophils and not IgE. So
if there's no rash, we have to suggest it, and if it's mostly gut symptoms and late onset, like 2 hours afterwards.
Yes.
Yeah.
So the history is the one that would tell you about food protein induced enterocolitis. And the other thing is that it usually, because people think, oh, this could be food poisoning, but it usually resolves also very quickly after they've had their profuse vomiting. And there isn't a good test for food protein induced enterocolitis. If the child was having bloody stool and you were worried that this was food related, you can do a fecal calprotectin, but again, it's a very non-specific test that just shows that you've had inflammation of the colon. And it's very expensive. It's not covered on Medicare. So I just tend to go on clinical grounds for that.
A quick question. Baby formula recommended if they have diarrhea with cow's milk formula?
Again, there's a lovely ASCIA, if I can find it.
If you say there's an ASCIA guideline, we can get people to look it up for themselves.
There's an ASCIA guideline that tries to look at, if you've got anaphylaxis, you should not be having the hydrolyzed formulas such as Allopro. and you should be going for either a rice-based formula or one of the amino acid-based formulas. If you've had enterocolitis, you may be successful with a hydrolyzed formula such as Allopro, or you can go for a rice-based formula. So those are the ones that you don't need a script for over the counter. Soya is recommended only in children over 6 months because there's a potential that the soya formula itself can also give you some degree of enterocolitis. That's the nutshell, you know, that's it in a nutshell. Sorry.
There's about 3 other questions. I'll just ask one more and then we'll let you keep going, because if a child has been diagnosed as peanut anaphylaxis by skin prick test, how often should they have the repeat tests and to see whether they'll grow out of it?
So if you asked me that question 2 to 3 years ago, and the child was under the age of 5, I would have said you only need to probably repeat the test every 1 to 2 years at most. And if the child is older than 5 and they've started school, I'd probably only test them every 2 to 3 years. Now, with oral immunotherapy, which I have not talked about at all in this talk, and the child is very young, and they've been doing the ADAPT trial, I would probably be thinking about repeating that test more frequently, because the ADAPT trial, which was the Australian trial where they were giving peanut to try and outgrow your peanut allergy in very young infants, when they first came for their first challenge, 30% of them were able to tolerate it, even in severe reactions. So I think I've changed my practice a bit and probably would do it at least every year in the first 5 years, because I'm trying to find that window where 20% of them might be able to have it reintroduced, even if they've had anaphylaxis.
Let you make the decision, because these kids should be managed by an allergist.
I think if they've had anaphylaxis, rather than just having some rash, then yes, we're probably testing them and going for food challenges more now than previously, because there's been a big push in the community for immunotherapy to try and modulate your peanut and tree nut allergy.
In the interest of you getting through your material, I'll stop asking questions and see how you go.
Okay, allergic rhinitis. You're probably seeing a lot of these kids as well. And I wanted to talk about it because it is a common problem, and I think it's poorly managed. Not because of you, but because the families just don't see it as a huge problem. They often go to the pharmacy. So in big studies, the ISAC study, which covered almost 100 countries, 6 to 7 year olds, 8% of these had allergic rhinitis, and teenagers, about 15% had rhinitis. So if you look at all children, about 20% have rhinitis. And you can have an early phase reaction, which gives you the acute sneezing and nasal congestion, or you can have a late phase reaction where they get more obstruction. So they could either have lots of sneezing and runny nose, or they can have that chronic obstruction. And a lot of these kids with chronic obstruction end up at the ENT when really they should be having more treatment of their allergic rhinitis. So this is a typical child, mouth breather, allergic nasal crease here, allergic shiners. You know, they often come, why has my child got these dark circles under their eyes so much? And they just get labeled as having large adenoids, which they may have, or large tonsils, or they go to the dentist, and the dentist will say, oh, you know, they need treatment of their nose because they're breathing through their mouth, and that's not very good. And it isn't very good. And I think it's under-recognized for what it is. Symptoms are usually the sneezing, which could be seasonal or early morning if you're worried about dust mite, rhinorrhea, that postnasal drip. Often these kids are thought to have either some type of infectious cough, but really it's the mucus running down the back of their throat. And we mustn't underestimate that these kids suffer from tiredness, headaches, fatigue. And 50% of asthmatic children also have allergic rhinitis, and 30% of children who've had eczema will develop allergic rhinitis because they get sensitized to dust mite through their skin early on in life, and then develop dust mite allergy. And again, it's a clinical history where they're having it all the time. They're often misdiagnosed as having a cold when really they don't have a cold. It was a huge problem during COVID when all these kids who were sniffly all the time, and I had to write letters that these were actually allergies and not COVID and didn't need to have constant nasal swabs. You need to look at that over many years, their sensitization will become positive. So again, early on in life, they could have negative skin prick testing or serum IgE. And as they get into their second decade, you'll find that more of them will have positive testing. So I would say most of the children that come to see me, if they're in their first decade, would have dust mite, and the pollen tends to be a latter thing, usually when they're teenagers. Don't forget that also there can be non-allergic rhinitis, which can coincide with their allergic rhinitis. So they might get worse with temperature shifts, like in hot or cold temperatures, like perfumes might set them off, or humidity might set them off. And they may have negative allergy testing, but they're all treated the same way. So the treatment is optimizing non-sedating antihistamines. They usually should have some trial of nasal sprays with intranasal corticosteroids. And now you can get over-the-counter combination one of Demister. You don't need a script for that anymore. And often they're not treated for long enough. I usually treat these children for at least 4 weeks to really decrease the reaction that's happening in their nose. And again, a lot of the chemists say, oh, you shouldn't be using the steroids for too long. The main issue is usually that they might get nosebleeds, but usually the amount of steroid that's absorbed is very little and doesn't tend to give you a lot of suppression of growth or the adrenal access. And again, Askia has a lovely treatment plan, which you can download. It sort of helps you define how to manage them with nasal steroids, antihistamine, how to do the spray. You need to sort of spray to the lateral aspect, not up the middle of the septum, so the X technique. You can put down your antihistamines, and you might want to use your saline irrigation if you've got lots of congestion. And again, don't be afraid to use it for longer periods of time than just a week, because it usually needs a longer treatment. And you could do the IgE testing in your older child to define that it's dust mite. So then you could do dust mite control measures. Or if it's pollen, then you understand that's when you need to treat it. And remembering that thunderstorm asthma, the trigger's usually perennial ryegrass. You know, they usually will have allergic rhinitis, which is undertreated. And when should these children be referred? Well, I think if they've failed conservative treatment, if you're unable to avoid the allergens, so for instance, they have a cat and they don't want to get rid of the cat. They've got severe chronic symptoms that don't improve with the standard treatment. And then you consider them for immunotherapy. And immunotherapy does work in children, and there have been good systemic meta-analysis which show that it does work. However, it's a long-term commitment for 3 to 5 years, and it's not covered on the PBS. So you may have families that have started treatment with me that go back to you for their monthly injections, or they might go on to the sublingual form, which in Europe they really love and is as efficacious as the subcutaneous if they don't miss any doses. And then finally, I wanted to talk about eczema. Now, eczema is such a common problem. 20 to 25% of our infants have it. And this is not a type 1 allergic response. Families will come to you and say, I want an allergy test because I think my child has allergies to X, Y, and Z. But you've got to think of it the other way around. Eczema is primarily an epidermal barrier dysfunction. So they've been found to have filaggrin deficiencies or other deficiencies. This one in particular can be associated with development of food allergy. So it's the skin problem that comes first, and then the food allergy that comes second. So if you've got eczema, 10 to 20% of your eczema babies will develop a food allergy. And food allergy sensitization does not always equate with the cause of the eczema itself. So this is where it becomes quite tricky. if you did do a serum IgE and you had very high levels, you might have that just because the child has a lot of IgE that's being made because their skin is just so inflamed. And really, food elimination in managing eczema is not recommended. Neither is routine allergy testing in eczema. But if you have a really strong history that the child has had the food and very quickly has reacted, particularly with hives or swelling, but that's different. That's a type 1 reaction. But if their eczema flares up in a delayed fashion, then your allergy test will be negative. And it's a fishing expedition for which food elimination is really a drastic, ill-advised, unsupervised problem in the community. And I think if anything you want to take home from tonight, you need to take a detailed history. If the eczema is flared up, but not immediately, then allergy testing is difficult. I would do a limited elimination of just 1 or 2 foods. If the eczema does clear up, then I would think about that it's potentially a T-cell mediated reaction and you might take it away for a period, but then reintroduce it, understanding the difficulties that you might actually be making things worse if you don't keep giving it and then get an IgE reaction, which is a problem. So you want to optimize the topical treatment. You want to control the itch with wet dressings and antihistamines. And again, people just hate putting steroids on their baby's skin. You could use Elidel as an alternative for the face, but really a lot of these babies end up coming into hospital and we end up putting them on Advantan fatty ointment. And that's what most of the dermatologists do. But I want to give you this. If you don't know about this, this is a wonderful website called Nip Allergy in the Bub, and they have a whole section on eczema and what is eczema, how to manage eczema, and they have some wonderful videos under managing eczema that you can watch, the parents can watch, and there's also handouts. And it's a wonderful resource if you don't know about it. And it helps families understand the skin and how to manage it. In terms of what's new in eczema, you probably have some families in which kids have started on dupilumab. I think it is a game changer for adults and children who have eczema. Here we are turning off your interleukin-4 and blocking that so that it doesn't continue the effect. And it's much better than the old-fashioned drugs that I used to use, such as methotrexate and azathioprine, who were like thunder, gunshot therapy. You can use it in children over 6 years. It has been approved. However, it's not on the PBS. So I think this is something, if you've got a child with severe eczema who's older, you've tried everything, refer them on for dupilumab, because I think it's a wonderful new medication that's changing people's lives. The other thing that I'd like to point out is that a lot of the information that I've talked about is available for you through the ASCIA e-training program. This is free, completely free. You can do it at your own leisure. You set up your own little account and it'll go through things like food allergy, anaphylaxis, rhinitis. So it's a wonderful resource, completely free. And it helps you understand how to best manage your families with allergy. So now I've got at least 4 minutes for questions.
Awesome. Thanks, Anna. An interesting one. A child about 6 years cut their hand on a tin of fish food, which was bloodworms, and they got local swelling and then a body rash. They started to get a cough, very slightly puffy eyelids, which settled with Phenergan. And the question is, should this have been given adrenaline? Is it always needed?
Great question. So in large studies where they looked at children with food anaphylaxis and they really pushed them in their food challenges to high doses, they actually found that a percentage of these kids self-resolved without anaphylaxis. Now, that's not the party line. The party line is that if you have a severe reaction that results in you having a cough, any throat swelling or difficulty breathing, they should have anaphylaxis. They should have adrenaline. So there is evidence that not all these children will progress to a severe allergy, and you may have time to have an antihistamine. I'm just wondering what element within that element did they have? Like, I've had reactions to snails. So I'm wondering if the bloodworms are in that same group.
Hard to know because it was a cut, it wasn't an ingestion.
Yeah, so
well, you know, unless they put their hand in their mouth to suck the blood out, I don't know.
Yeah, so that's very interesting. And then we'd have to actually get the same tin of the same bloodworm and scratch test them with that, because I doubt that there's a serum IgE that you could test.
Yeah. Totally changing subject. Is eosinophilic esophagitis on the rise? And what are other ways, apart from endoscopy, can it be diagnosed?
I don't think it is on the rise. I think that was always there, and we just probably ignored it.
Maybe we recognize it better now.
I think we probably recognize it better. Diagnostic possibilities without endoscopy. Well, in the United States, they do this swallowed technique where they try and pull up cells from the esophagus instead of having you asleep, an endoscopy, and then they smear that and see if you've got eosinophils, and a certain percentage would then count as being eosinophilic esophagitis. A serum test is not being useful at all.
Okay. I think I'm going to ask you the most controversial question, which
Go ahead.
what about children diagnosed with leaky gut on testing with oral mannitol, which is non-absorbable when it comes out in the 24-hour urine? Does this lead to more food intolerance or reactions, and can treating leaky gut help?
Okay. Personally, I have never done this mannitol test, and I don't know who's doing it.
Probably a naturopath.
So, but if you go back to that slide of mine where we looked at the gut and how that antigen is seen, I think it's not just a leaky gut. I think it's the wrong type of microbiome that is growing there, that is not promoting the T regulator cells to be active. So when they think about the leaky gut, they're saying that your allergen is coming in through the enterocytes, being seen by your immune system that lines your intestine, and then developing sensitivity to it. And so just because you have the mannitol test that, you know, I think if any one of us had enough mannitol, we'd be leaking too. I don't think it's a bona fide diagnostic test, but I can understand the pathophysiology of what's happening in the intestine as a way that you may be promoting the inflammatory response if you don't have the right microbiome and you aren't breastfed and you have food proteins that aren't broken down coming in. So food proteins that aren't broken down are the ones that may not be digested properly or broken down, and then they're seen as being foreign. But the other compounding thing is that if the kid's got eczema, they're going to have inflammatory cells also in their skin, and you may be touching them with the food on your hand and then on their skin that's inflamed, and they may be sensitized through their skin, not necessarily even through their gut.
That's a very interesting response because there's a follow-up comment from the poster saying the test was done by a GP who's done holistic training, and it's often in atopic type pale patients with food intolerances. So that theory of maybe the exposure's happening on the skin might have some
Well, if they're
correlation.
atopic and eczema is going to present in
Yeah.
that sort of 6, 8 weeks, 4 months, and it's not being managed, we're thinking that so that was a lot of work done from the UK and Gideon Lack's theory about that you're not exposing the child correctly. So we do need to have gut exposure because we want the T regulator cells to be up-regulated to develop tolerance. And we know that prebiotics grow good probiotics, which then release certain things that will become, because those bacteria need to live. So we want tolerance to be happening in our gut. Otherwise, those microbiome won't survive.
As I predicted, Anna, as soon as you start answering questions, a whole lot of other questions come through, but we've come to the end of your time.
Oh, what a shame.
Thank you so much for your talk, and I'll hand over to Lauren to close the night.
Thank you again for speaking, Dr. Dosen. It was such a great presentation, and Martina for managing that Q&A. And thank you all for participating as well.